in patients diagnosed with multiple chronic conditions. I do so using genetics and then informatics approaches. And on the informatics side, I do natural language processing of notes from the electronic health record. And then also I am big into working with All of Us data set. So as part of from my personal interests for collaboration with pharmacy is, of course, these patients with multiple chronic conditions and thinking about like polypharmacy and, you know, the management of their conditions and how best to extract this information from electronic health record sources, how, you know, best to use the pharmacy information and just considerations for that. And like Young G, you know, where to start with establishing those collaborations, because I think we could do something, you know, really great in terms of the polypharmacy, the symptoms, and multiple chronic conditions.
Thank you so much. Teresa, correct?
Yes.
Thank you, Teresa. And I think there's so much that when I start looking towards some of our work with medication adherence, which actually came from a collaboration with our School of Computing and Information, I think we'll see that even we learned a lot about how the questions we ask related to adherence are well informed when we have these cross-disciplinary conversations. So I'll be sure to keep that in mind and be sure to at least ask for your thoughts and feedback about where interactions might lie for a project like that.
Right.
Thank you so much.
Thank you.
Yeah, thank you, Teresa, Youngji. Again, Annette, for having me here, because I think there's a lot of opportunity and value when it comes to sharing what we do. By no means will today be a comprehensive review of opportunities when it comes to collaboration, but I hope they spark the discussions that lead to further conversations. So I'm excited to have the first of many conversations today. And I'll jump into some of what we can look at with slides. I will try to run through. I did my best in trying to pull a variety of projects that we are currently working on. Without bearing the lead, I will say we're very interested in working with consumer-facing technology. We've started to work towards more and more data-oriented approaches. A lot of these projects are either internally funded from opportunities like the Pitt Seeds or Momentum funding, and we've just recently been putting out more and more extramural approaches, an example of which would be work with our School of Computing and Information, local family and primary care, looking at social determinants of health and how the assessment and documentation process take place. So with all the great work that was going on and all the value in our collaboration today, I tended to only pick and choose a highlight of representative examples, and I'll look forward to interrupting questions and discussion points. I can probably better term that when I think about what that means, but I'll encourage folks to share in chat as well as to chime in with a question. I'll do my best to pause as we go throughout. So as I jump into some of our slides, I'll do a quick check. Is the slide share currently sharing or visible to the group? I see nods, thank you. As we look at technology at Pitt Pharmacy, I wanted to be sure that I talk to the structure of what we offer. And when we think about our faculty, which is fairly small in regards to how we look across our schools, we have our two main departments, the first of which is pharmacy and therapeutics. This is where our doctor of pharmacy, as well as our overlap with the Center for Leadership, Innovation, and Practice with community pharmacy tends to sit. In that clinical four-year doctorate of pharmacy program, we have, of course, our clinical research that's been done in incredible length and depth when it comes to community practice. How are we building the opportunity for the thousands of community sites for our pharmacists to deliver services while often being recognized in the past for a product? So there's an incredible depth and breadth of information that's being discovered and shared across research when it comes to what are interactions or perspectives of patients when they look at their independent pharmacies or their corner drugstore from CVS, Rite Aid, Giant Eagle, etc. And that extends from very discrete studies, how are patients interacting with these pharmacies? Are they mainly calling for their refills? Are they using their apps for their refills? To broad policy-based research to say what should or could be reimbursed for that could lead to large outcomes and impact. In addition to that work in the community, we of course have our fantastic clinician collaborators who are in practice, both in the hospitals and in ambulatory and outpatient care settings, doing a fantastic variety of work with discharge and maintenance of patients at transitions of care, et cetera. In addition to that department, we have our pharmaceutical sciences, where we more traditionally consider our bench science, our MS and PhD work, a huge, fantastic recognition of our work in recognition of pharmacogenomics, an immense amount of work with faculty in patient safety, looking at disease states in areas such as chronic kidney disease, acute kidney injury, traumatic brain injury, et cetera. So when we're looking at our two major departments, that's something I wanted to make sure we have a chance to broadly share. And to Youngji's earlier point, if we were thinking about these collaborations, there are unique opportunities with both of these departments. However, when focusing on something clinically oriented or related to workflow or practice, we may tend towards something like our pharmacy and therapeutics. I'll also share a couple of examples, of course, beyond my own scope. For example, a partnership between the School of Pharmacy and the School of Health and Rehab Sciences at the recent opportunity to educate practitioners and patients for over-the-counter designations for hearing aid that has taken place just recently. In addition to these two departments, we have our other educational pathways, including our Master of Pharmacy Business Administration, focusing on mid-career professionals and not quite the MBA approach, but rather focusing on the blend of specialty pharmacy, community pharmacy, and the industry. We also have a developing pharmacoanalytics master's, which has been a fantastic collaboration, not only with our school and folks like SCI here at Pitt, but also the School of Public Health has been an overlap in some of those opportunities. I'll jump into a little bit of the structure of how I've created my work in what I have been leading in the last 6 years, our Pharmacy Innovation Lab, and less so of just talking about our work, but rather how we've structured and why the organic growth of e-health, or as we look at it, digital health and pharmacy, have been a little bit more broad to start, and then some of those specific research examples. Before I continue on, I wanted to ask Youngji, does this help at least give you some of that background when you're reaching out to our school, how to think about our different categories or departments?
Yes, definitely. Well, thank you so much, because my only, the knowledge about the first school pharmacy is PharmD and the PhD, but I didn't know about the pharmacoanalytics, the business administration. So yes, it's really helpful. Thanks. And also the innovation lab.
Of course, and I'll jump into that now. I'll pause again for questions and comments as I very quickly run through the philosophy, a very brief definition for innovation of anything that's new and useful. And that's incredibly broad and a lot of buzzwords, but I really love using this both as a framework for our education and our research, because a lot of what we find in practice may have already been done in the world of engineering or business. And we have to think about reframing that, whether it's on a consumer side, in a workflow orientation, when we think of assessment of data collection, et cetera. So when we think of our Pharmacy Innovation Lab, the three components that we look at would be our curriculum, the research that we do. I broaden it to projects since we have a variety of work for our educators and faculty that may not be solely publication outcome oriented research, but rather small partnerships to address things like assessing patient technology for a very specific use case, whether it be for a clinical trial or for a patient at a clinic who's trying to expand the scope of care that they're able to provide. And then the partnership that I think is important, something that I mentioned to Annette when she kindly offered the chance to connect with the eHealth horrors, was the value of what we do is recognized certainly in the academic work and some of the funding that we can approach, but some of our industry partners or partners in practice like regional health systems might offer some interesting support and pathways for deploying technology, or at least understanding how it's being used. So a component that I did want to speak to would be some of our courses. After I speak to our research, I want to at least highlight how we're including our learners, because that's such an important area for myself, as well as some of the events like our hackathon that we held just this past month. So as I jump into our research. I'll pause for any questions, reactions to what I've shared so far. Excellent. And thank you, Annette, for the comment in the chat. I'll start with our research by, again, giving the note that this has been developing over the number of years, and I choose the projects that I do to highlight the relationships and at least the framework. So both with pardon and with anticipation of questions, I use at least the frameworks for posters as examples to how we framed our work in the past. The first that I wanted to address was our collaboration with our School of Computing and Information. This was fantastic work that I've been lucky enough to work with partners like Jacob Beal from our School of Computing and Information to look towards medication adherence. When we think about e-health, the reason this particular idea came to light came with the blend that we had our relationship with SEI, who could think about the technology to be implemented. What's the in-home experience related to medication adherence? And with the great work of Dr. Beal, who joined only in the last few years here at Pitt, coming from an industry background, we could find, for example, off-the-shelf cheap technologies, COTS, cheap off-the-shelf technology, to think about what patients would be able to accept. The broader work of this particular approach was to think about the deployment of in-home sensors that can identify, for example, location spatially of where somebody is in their home, such that if they can establish a routine, or these sensors could help define a routine based on the location, the data that's captured, and the orientation of what is learned from that data, we might be able to understand or better define when there's an aberration in a patient's schedule, or when we're looking at mealtime dosings for medication. In order to get to that goal, and that goal represented NSF submission and an NIH R21 submission, we wanted to find our preliminary data to support this work, but also learn more about referencing the Pitt plus Me research registry. So in this work, qualitatively, the last, I want to say, year and a half when this was published, we did in-home interviews, which goes to show how long ago this study was initiated. We did half of our interviews in-home to identify both the behaviors around medication adherence, as well as technology acceptance related to spatial recognition of where somebody was in their home. Some of the themes that came up, and we're all paused to ask Teresa when it comes a little bit to experience, the interesting takeaways that we had from these qualitative approaches was the relevance of cohabitation. When we think of the resources that a patient might have living with family or living with caregivers, we would anticipate, or at least I would hypothesize, that a correlation from cohabitation, the people you live with, might be an influence in the positive as to reminders or behaviors related to adherence. The interesting takeaway was that we found med adherence to be a more personal experience. So our cohabitants may not be included in the care of, say, a spouse or somebody who they're directly related to give or provide care, because they didn't necessarily want the negative associations at the time when there was a missed dose or when there was a new addition. Having that reminder of, did you take this, might not be a compelling relationship for somebody that they lived with. But this offered this interesting pathway that our technology wouldn't necessarily just be the reminder of when something was missed, but could we support the daily activity that the patient was experiencing? If they do, for example, commonly take their medications either in their 7-day planner or box, or in a separate container with them when they go to work, is that the relationship that the technology should support, as opposed to whether or not the medication was or was not taken? So this is an example that I wanted to highlight: collaboration with those who think technology first, the value of some of our qualitative approaches, and then our pathways. So far, nothing funded yet, but we're extremely excited to get this content out and published such that we can use it as preliminary data as we pursue further opportunities. So I want to pause to Teresa and ask, does this at least shine a light about some of the work when we think about adverse events or reporting or polypharmacy from your work, and generally to the group, questions or comments about the project or the relationship?
I mean, I think it's fascinating what you have here. I personally don't do a lot with adherence. We have a number of researchers in the School of Nursing who have a focus on medication adherence. So I think would be very interested in this, but this just shows how much you need to have that patient perspective, that patient value, before you're developing any kind of technology. My work is more from the usability of information that's already in the electronic health record. So I'm coming at it from that perspective, but fascinating. Thank you for sharing this.
Yeah, thank you for that feedback. And when I move on to Annette, I do want to share as a takeaway from learning to what Teresa you had shared. Medication adherence, we live it as practitioners and in our schools, but that unique takeaway was thinking about how a submission like this to something like CHI, a very human-computer interface oriented framework that we had to think about, lent itself to these different value perspectives that clinicians provided to this kind of work. And so we found challenges in that light too. People would say, well, we've worked on this problem for 30 years. What makes this unique? And we had to be very clear, both in how we approached our publication, but also some of those challenges from NSF and NIH when we had to define the innovation of our work. So learning in our own frame as well. Annette, your hand is up. I'd love to pause.
Yeah, I just wanted to say this work reflects so many different approaches that cross disciplines. Like this going to the home is almost like a contextual inquiry about what's going on with medication taking. And I have been doing work for quite a long time in adherence to transplant medications. And the most recent work was with adolescents and young adult kidney recipients and their parents, if they were younger than 18, and their providers. So I noticed in this poster, you do have provider insights. So how was that data collected? I'm just curious.
Yeah, it's a great point. Thank you, Annette. And something I do want to share too. You were as a note to our other attendees, we had a conversation many years ago about another project that we had looked at when it came to getting medication lists out from an EHR using a FHIR standard. And that was one of those ad hoc conversations that I hope we can continue in this framework. To your earlier point about the clinician perspectives, we had conducted interviews with prescribers in a family health setting and pharmacists in community settings related to their preferences when it came to learning about or how they approached assessing adherence. So when we can think about those two pathways, at least the contextual inquiry on the patient perspective, we wanted to see how it was either recorded, observed, or experienced in the clinician workflow. So that was the complementary approach. And the way that we had framed it was pharmacists in a community setting, and specifically prescribers, doctors, and physicians in a family health setting.
Okay, thank you. Looking forward to hearing the rest of your.
Of course. Other questions or comments before I move on? Excellent. Let me make sure that thank you, Ned. I just wanted to make sure that I adjust the hand raise too. All right. So as I continue on with our next project, a framework that we looked at and have worked towards at this point at the level of a systematic review, and this is more prospective in the work that we're looking at, to Youngji's point, when it comes to consumer health facing approaches, one of the takeaways, or at least one of those organic considerations that in the last 6 years we've been most intrigued by has been the accessibility of consumer health technology. Often what I've experienced, and I'm very editorial as I share this, there's some great work that goes across the development of the technology that could be framed for use in home settings. But one of the frameworks that is particularly interesting is identifying what is currently in use, or at least leverages that pathway. A close and dear colleague of mine in MCPHS in Massachusetts often mentions the interesting academic challenge that we've looked at cell phones as an opportunity now since before the iPhone. I know that this work comes esteemed from our own colleagues here at the School of Nursing, where PDAs were an incredible pathway or opportunity to connect with. So as we think about this framework, or the way that I think about approaching some of the research challenges is recognizing both the role and the potential or lack thereof for consumer technology already in use in the home. And a smart speaker has been one of those frameworks that at this juncture in my presentation to you all this morning, I think raises very interesting research questions. An example that we look to, at least in this survey that we'd be most interested in, is identifying what current interventions have been used specifically with a consumer device, and looking towards our Google Homes, Echo Dots, or Apple Home devices. The reason I say that's specific, because we've looked at conversational agents, embodied conversational agents, and chatbots, at least in our literature for a good number of years now. The challenge, or at least the gap that we wanted to address, and personally, the area that I found interesting was that form factor. What does audio or discussion look like for an in-home device that may or may not be used for that purpose already? So this is much more prospective work. Currently, I am going through a systematic review with a colleague from Illinois State University to identify what work has been identified or conducted specifically with health-related outcomes and these consumer devices. Not necessarily anything on a cell phone, not necessarily a chatbot on a website, or specifically made for something like discharge in transplant patients, which we have seen in practice. We want to understand, what is the Google Home or the Amazon Echo doing for patients in their home right now? And that's characterizing, do they use it just for something like music or for controlling smart home devices? Or have they used it as a reminder in any capacity? This hopefully echoes or resonates a little bit with our user acceptability in that first study that I shared. What can we understand the problems and needs of patients in practice, such that we can use technology, or at least think about technology in ways that we can deploy? Interesting learning from my early discussions has been as a stakeholder for our capstone course for undergrads in computer science, being able to learn from them about frameworks when we think about developing, for example, an Amazon Echo skill that could be deployed to a device, also has pathways that, by using a specific platform and framework, makes it fairly device agnostic. So it was just interesting learning from me to learn about the development process when they are coming up with at least some of the call and responses, how those call and responses might translate from a Amazon Echo or AWS based skill that can or may not translate to something that could or could not be done on a Google Home. So I apologize for tangenting a little bit, but that's the takeaway. As a researcher, we learn very quickly what we don't know. And one of those challenges when it comes to e-health or digital health, some of those limitations, if we do come up with an intervention for a device, how narrow does that make our research question? Do I have to ask prospectively after this systematic review, what is somebody using their Google Home for? And does that differ from what is somebody using their Amazon Echo for? Relationships with the cell phone app notwithstanding. So I'll pause. I know that this is a little bit of a jump from some of the other projects that are a little bit more retrospective to the data, but I wanted to pause for questions, thoughts, and comments here as well.
So Ravi, I have a question. So, well, thank you so much for introducing this fascinating idea. So, would you or the other researchers are open up for the potential collaborators on these, upcoming or the ongoing projects, like the previous one that's already completed, so it's done, but like these systematic reviews or the presentations, other works that you are going to introduce? Would you be willing to collaborate with the researchers, if anyone's, well, actually including me, like they wanted to be more involved in it or collaborate, to build up future collaborations? Or
Absolutely. In fact, some of the in-home studies would probably benefit from other pathways as we move forward. To the consumer device thing, the consumer point, the value of user acceptability, I think, would be immensely supported by your work and perspective, Youngji. And to what Teresa had shared earlier, our assessments of things like SDOH, social determinants with the EHR, certainly open to it. So I hope I'm not answering too much for other people, but rather we as pharmacy tend to be, and I'm speaking for myself and I'm just projecting, we tend to be very focused because we don't see a lot of either medication focused approaches or the value of the services around those interventions. So we'd love to have that collaboration and conversation.
Right. Yeah. Maybe I can contact you later. Yeah. Later work. Thanks.
Of course. Thank you. Other thoughts or comments before I continue on? Wonderful. And Annette, I appreciate again how kind you were in giving me the time, but I want to also recognize that if there are other discussion points, to be mindful of time as well.
Oh, please. I mean, we're all in this together, and Youngji is the co-director. I mean, we've all been involved in this, so I might have been the one that initiated the conversation with you, but we're all interested in your topic.
Sure. Well, thank you for that. And as I turn back, I'll shift a little bit. So we looked at consumer technology as we thought about some of the questions we have with patient experience, medication adherence. Something I want to reflect as an educational collaboration that has come to light and has, as we all learn when it comes to working, offered many pivots as we've learned. I want to share this particular project with augmented reality. Dear friend and colleague, Dmitry Babichenko from our School of Computing and Information has been a longstanding partner with this project. How do we use augmented reality for training our students for sterile or aseptic technique? So a framework of how that problem statement came to light, with each PharmD class, Doctor of Pharmacy, we have about 110 or so students. And the challenge when it comes to learning about aseptic technique, working in, say, a sterile hood with negative or positive pressure, being able to think about what minimum requirements we need for accreditation standards, but Pennsylvania not being a state, examples like New York, who require an aseptic technique as a part of licensure, we found this unique challenge that physically we only have so many hoods that we can use in order to teach our students about not crossing, for example, a hand in front of a hand to break that sterile airflow. So a collaboration with SCI and Dmitry Babichenko led to, I think it was 4 or 5 iterations how we might use augmented reality technology. I'll share here and I'll make sure that my share has been optimized for sound and video. And I'll at least demonstrate a little bit of our learning for what it meant to collaborate in developing these devices. We won't show the whole video, but I'll share at least the highlights.
My name is James Finkel. I'm a senior here at the University of Pittsburgh. I'm a computer science and psychology major.
So my apologies to James, but as I come through, I want to ask, is the video sharing appropriately? Thank you, Annette. So as James demonstrates here, we had to learn about the use for augmented reality, or at least the development cycle using platforms like Unity. In this case, how would we rapid prototype with a Pitt ID as a framework? The goal being, can we extend this augmented reality information keyed to a specific device to something like a syringe or an IV bag that could help identify in that moment what the value of sterile or even procedural processes might include. We could imagine something like an alcohol spray bottle representing a step 1, sterilize your field, and then step 2, showing the highlighted syringe as a pathway. As we walk through this takeaway, we see our grad student here, and in the video, which might be a little bit small, we trained our computer vision models to identify what was a saline bag and what was a syringe. So as the CV, the computer vision identifies the bag, we see our grad student training these different models to identify if a student is in a field or if that webcam serves as an ad hoc placeholder for something like a sterile hood. How can we extend that to a learning platform, or at least the protocol as an educational approach that exposes students to this sterile field ahead of time. There's a few other components. For example, we've changed from having it based on solely a platform like a laptop or a screen on a desktop to using something like the student's own cell phone in a plastic headset in order to make it something that's a little bit more scalable that a student could take home, practice in anticipation of an in-class lab or skills workshop, and then have some assessment when that technology is ready. The arc of the experience, or at least the challenge that we see when it comes to e-health and the incredible patience and resiliency of colleagues who work in technology, was finding the appropriate resources. The amount of effort it takes just to build what you saw in that technology can be significant. And we're lucky that we had our capstones aligned with these undergrads who had previous experience working with Unity, and a grad student who needed a project to extend over a time period in order to make that work. As you see, Train AR was the title we used in the video and for this particular device, but it's version 3. I think we ended up with version 5 in the most recent iteration. So it's a foray into building our technology. Our current physical location at Salk Hall, just across the street from our BST and School of Medicine, is actually recently renovated. So we invite everyone to say hello, but we've also specifically dedicated space to virtual and augmented reality, at least in our educational platform for anatomy and physiology, or as we explore more opportunities, frameworks like sterile compounding, or even capture of 3D or 360 video of what procedures look like as an opportunity to expose students in anticipation of their skills or lab. I'll pause for our augmented reality before I go on. Questions or comments? All right. This is one of the most recent projects that we have been working with, and it's one of our, for anyone interested in either HCI or information processing, it's one of the new formats that we've seen but not necessarily practice with for poster reporting outcomes. In front and center, the vSafe platform. Theoretically, all who have received a COVID-19 vaccine were eligible to use the CDC reporting platform vSafe, which participants signed up through SMS and which automatically sent a link from whatever platform and device was recognizing that text to the patient to identify adverse events and as reminders for second doses, which goes to show how long ago this idea came to light and how much we've collected since then. The goal for this particular experience has been to characterize who used this vSafe platform that the CDC had released and what were their motivations for use as defined by Likert scale agreements to things like, I wanted to contribute to science. I wanted a reminder that let me know when that next dose was. And I wanted to help address things like vaccine hesitancy by my participation in contributing back to the data that was collected. This is a quantitative survey that's being distributed by Pitt plus me. So we had reached out close to 1,000 or so participants. We cast a very wide net to see what we could learn about who was using it and some of those motivations that would lead to it, with the goals of working towards a publication in something like either our pharmacy-focused approaches, like our Journal of the American Pharmacy Association, or depending on how much value we get out of our usability assessments, things like the system usability scale might lend itself to something like the Journal of Medical Internet Research, JME, or Human Factors. The extension to this is asking more broadly, what's the role or interest in patients related to patient-reported outcomes? What was that motivating factor with as wide a net as the hundreds of millions of people who received COVID-19 vaccinations to participate in this? And can that learning extend to patient-reported outcomes in other lights? So I realize I want to be mindful of time to end and make sure we have some points for discussion as we can allow for, but I wanted to ask questions or thoughts, comments related to this, a patient-reported outcome platform that we wanted to assess and characterize use and definitions for. And I should mention, it was this project that when I saw another project led by students out of the School of Nursing who were trying to identify adverse event experiences with the COVID-19 vaccination, that I reached out to them and said, hey, I think we're at least asking very similar questions. And it was through that fateful interaction that I had a chance to connect with Annette. So I wanted to recognize the unanticipated value of a project like this. All right, I'll be mindful, say in the next 5 minutes, I hope to wrap up, and I will certainly encourage any questions as they arise in the chat, or hopefully when I pause to make sure we identify the outcomes that we can at least speak to, or questions and discussions today. I did want to highlight one of the unique opportunities we had 4 or 5 years ago at this point, and that this is what led to our initial discussion. The Medivate project was take off as a winner from the Pitt Innovation Challenge, hosted by the Clinical and Translational Science Institute, CTSI. Faculty and students came up with the idea of having a med list available on the phone. When we think of consumer devices, I will acknowledge that iOS in their most recent iteration has a medication list for anyone with the most recent iPhone and iOS can now enter their meds as something to take with them, a part of Apple HealthKit. So very interesting research area. This was before then, when we tried to identify what is the opportunity to specifically share a medication list from the EHR using the Fast Healthcare Interoperability, FHIR, standard, such that a patient at the point of discharge could be provided a QR code. If they had this Medivate app on their phone, what it would mean for them to scan it and then have that app on their phone with their fully identified medication list. A huge amount of learning. The role of the Pharmacy Innovation Lab in something like this, working with an incredible set of colleagues, Phil Empey, who has done some incredible work with pharmacogenomics, and Jim Coons, who's an incredible cardiologist, pharmacist, practicing and teaching at the school. The role of the Innovation Lab was something that is near and dear to my heart. We manage more or less a student team that served as user and stakeholder experts, serving for the UX, the user experience, identifying what were the steps for the patient flow in terms of discharge. How did that lead to their expectations from their cell phone or their discharge experiences? And coming up with the personas of what were clinician expectations for this med list at the point of discharge, but then also returning, specifically in the case of heart failure, to a pharmacist like Dr. Coons in practice. So in addition to coming up with this project, which did eventually survive the security challenges of getting through the university, and it got through its first trial, but then got held up and still exists at the level of funding and trying to work through. It was just an important takeaway in learning when it comes to e-health and digital health, the value of not only mapping with the UX, the development of UI through rapid prototyping, our paper prototypes here on the right, our digital prototypes using Figma, Adobe XD here in the middle, and then eventually something that was published by the university on the Apple App Store back in 2018. So as we walk through a couple of the challenges and opportunities, it wasn't enough just to build the app. We also had to make sure that we advertised it. In this case, we had a partnership with Giant Eagle, and like any good product, it had to pivot a couple of times. So rather than starting with a med list at an inpatient level, we had an opportunity to collaborate with a community partner, the value of what we see here locally with Giant Eagle. As they were doing their flu clinics, we created a version, or at least an extension of that technology, creating a Firebase standard to export or at least make record of something like a flu shot to see the value and feasibility of this device. Some other work that's currently being done, Lucas Berenbrock, who I mentioned as our record and pharmacist here at the School of Pharmacy, partnering with colleagues at the School of Health and Rehab Science and Audiology when it comes to increasing access to education with OTCs. The CHAMP training program is available through Pitt Online and has a variety of options when it comes to training and the qualitative and quantitative research that was done related to clinician confidence when it came to how confident at the community level did a pharmacist feel when it came to identifying appropriateness of OTCs or when to refer. So using that qualitative background that Dr. Berenbrock and our partners at SHRS were able to identify, creating this CHAMP educational platform, which is now available, I think, as a CE granting certificate, or not certificate, badge, I want to say, here on Pitt Online. So there's still an immense amount of work. I want to be mindful. There's 12 minutes left in our original hour together. And I have a handful of slides to talk a little bit about our education, but I'll leave to yourself and Youngji if you think a discussion would be more appropriate now, or if we want to share a little bit on how we approach education in e-health for these topics.
Other participants want to explore research-focused topics, or any comments before moving into education? I have one thought that I hope doesn't take up too much time, but just to plant the seed that after hearing your presentation today kind of prompted me to think, and I have to say also seeing Heidi on the call always reminds me of theory. So when we think about the potential or the capacity of convergent research projects, crossing disciplines, and, you know, putting the best from each discipline together of what's known for a phenomena, do we need different, more robust theoretical frameworks to guide that kind of work? Or would it be what seems to be more typical of within a project, you have sort of a theoretical approach, and it's more circumscribed for that project? So I don't know. And at this point, I don't really think, I think that would take a whole discussion in itself. So I don't really expect an answer, but I think we should be thinking along those lines of big picture, umbrella type work, and within that, maybe the smaller pieces. If anyone has any comment on that, I'd be interested in hearing about it, or we could use this as a topic for a future discussion.
I think we can use that for future discussions. And actually on top of that, well, I just got back from the conference, the AMIA. I don't know, Ravi, the School of the Pharmacy also attending to the conference, but that is conference for American Medical Informatics Associations. And actually one of the lessons, one of the thoughts that I have during this conference is, well, actually, I was the only one from the Pittsburgh to attend the conference. Unfortunately, there are a few from the rehabs and very few from the DBMI. But this year, I saw some very fragmented work across the campus. So, but when I look at the other university, they have really the strong collaborations, but not only just collaborating works, but actually they just keep, showing themselves up to those, national conferences, kind of promoting the schools and the works, how these multiple, multidisciplinary teams work together. So actually, I was going to ask Ravi at the end of the presentations, maybe not only just we keep having the presentation, this is a really great things to also to know each other's, but we definitely need to start thinking about as the eHealth Hub level, what conferences that we should target and how to, brand ourselves, because we have so many great works. Well, sometimes we can call it informatics, data science, but nowadays it's all these umbrella terms like health technologies but yes, people really don't know that we have so many great researchers working in these areas, and not only within the school, but across the school. Ravi has really, presented so many great ideas, e-homes, or even the consumer health informatics, but it has not been presented. So people really don't know, and not many, so I think that is the thing that we may lose the future researchers or the future students. So maybe next week or something, we can also talk about how we can actually collaborate and target some national conferences, work together. So at least submit a small pilot projects or the even reviews, whatever. So just let the people know we are here to work very collaboratively. Yeah. I know it's a little bit off the topic, but I just wanted to add that one. Yeah.
Thanks, Youngji.
Yeah, I was just going to say, I think it'd be really, the more we pursue these interdisciplinary collaborations that are, I think, not just interdisciplinary, but across the life course and across disease sites, that we'll begin to see more and more need to adjust our frameworks, right? We learn about sort of the different ways of knowing in these different professions. We've been seeing that a lot in family caregiving research when we start bringing in the public health, the sociology. Occupational therapy has been tremendous to sort of reframe some of our thinking in the School of Nursing and then social work, and start to realize those things that when we stay in our own fields, we sort of have a blind spot for these other really important factors that we haven't been including in our studies. So I just love, Annette and Youngji and Salah, this real emphasis on bringing people in from the different schools of the health sciences to really help us think in different ways. So congratulations on that. So I would love to have further discussions on this. Absolutely.
Sounds like we'll plan something for that. But Ravi, you do have, unless someone else wants to say something, you do have about 5 more minutes if you want to give us the highlights of your educational work.
Yeah, I'll run through quick, but I do want to highlight 2 things in regards to our work with data. I haven't had a chance to really capture as well, so I'll certainly reach out to Salah and Teresa separately. As we think about our education, 2 things come to mind. One are partnerships. In this case, we have a few 1-credit electives that we have our students working with startups who are involved or work around technology. And we think that this is an important takeaway for not only how e-health exists, but when we think about the vast amount of venture capital and development and often failures that take place in that framework, and that we had talked about SBIRs as just interesting frameworks for these pathways. I think this is a key takeaway. Here we see our 3 pharmacist-founded startups between parcel health, sustainability, so replacing that amber vial that we think of with recyclable cardboard, DocStation, creating a clinician-focused first billing platform for services, and Cosmos Health creating a user-first experience for med resources. How do you counsel patients within 5 clicks with something that's meant to be read as opposed to micromedics? Other ways that we've thought about these projects that come to light, the wait times in pharmacies for anyone who has had to wait for their flu shot. We thought, hey, why don't we look at the industry and see what's happening? So as a part of an independent project, Domino's has told us where our pizza has been for at least 7 years now. And so our students came up with this framework and worked with another stakeholder group for a capstone to create a manual version of updating what a pharmacy dashboard might look like. If you go into the VA today, I believe at their AmCare, you'll see something that looks similar. I do want to share, we did create a Python for data management course for completely novice, very afraid of technology clinicians, who I'm sure Salah and Teresa might have a chance to hear about, or at least experience firsthand. Interestingly enough, we developed this as a co-taught course. Again, SCI, my colleague Dmitry Babichenko. We have since in 2018 split the course because of its popularity, but we find some interesting frameworks of not reinventing the wheel when it comes to at least introducing, even if they don't know what a for loop is whenever they leave, they know those challenges of saying, well, what if we took an 11-digit NDC code, National Drug Code, that has dashes in it, and we wanted to compare it to a list that didn't have dashes? Much easier said than done as our students learn. Another project that I'll at least mention to Teresa, we're trying to define and quantify. ICD-10 codes are probably not how we can best qualify or quantify the progression of things like oncology for patients who have shown calcification as a progression to bone metastasis. So as a very preliminary project between myself and a colleague, we're looking at using CTAKes for clinical concept mapping. If anyone, yourself, Teresa, or anyone on the call certainly has background in NLP, I feel like that is a potential pathway that we can look towards, much less Youngji's fantastic work when it comes to the consumer-facing approach trial. Last I mentioned, not our consumer augmented reality video, but for anyone who remembers Google Glass, our students came up with a video to say, what would community pharmacy look at? The fact that it was in 2014 and now seems ancient because the technology is either outdated or now focused on enterprise gives a chance to show, at least we could expose our students to this e-health concept early. I did want to share, if it didn't work, I apologize, our hackathon as a takeaway. The last slide is the value of taking our clinician learners and giving them 24 hours to come up with a challenge or with a technology alongside their colleagues in computer science was a fantastic experience. This is our 6th annual year that we held it in person just this past October. We had around 300 folks register, the total of which resulted in 23 pitches, all available online on that DevPost submission site. The winning places included virtual reality for Alzheimer's, looking at diagnosis for melanoma, and one of my favorite stories, Fosco. The majority of these teams did not know each other. So having in 3rd place a student in the medical school, a major in psychology, and somebody from computer science who happened to be walking by the event that weekend say, hey, let's go ahead and make this project, was just particularly exciting. Certainly an open invite to all students of nursing, undergrad, grad, PhD, etc., but annual and recurring events. Thank you so much to Annette and everyone for their attention. I know this came a lot at once, but I appreciate all that you had a chance to offer in the discussion. I'll leave my name, which is my email, here in the chat, just Ravi Patel at pitt.edu, should anyone want to follow up.
Thank you so much, Ravi. You've planted the seeds for lots of collaboration, and I look forward to talking to you more and hope you join us for some of the other updates from the overviews from some of the other departments. And so any other final thoughts, anyone, before we close?
I think, well, just a quick ideas. If more and more people, I mean, I can see already several people wanted to have the collaboration. So maybe in the future, maybe early next year, we can plan for like the few, Ignite calls, from the school pharmacy colleagues and from the nursing. So, like if each of us can just present like 5 minutes, really just quick talk, and then current works and the work they would like to collaborate with, like potential ideas. So we can kind of have the all, kickoff meeting together and see,
Right.
our future matches. I mean, like the
Well,
research match. Yeah.
Right. We'll have to make this a more formalized mechanism of how to really move forward with some of these collaborations, which because of the holidays, we only have a few more slots for overviews, but we've already slated January time to talk about some of these logistics and really prompting these linkages and everything. So I look forward to that as well. And I have to actually let someone in the house right now. So I'm going to close for now. And thank you so much again, Ravi. Very interesting, stimulating work.
Thank you for the chance.
Bye, everyone.
Bye-bye.